champions out there, we are going to be having a discussion about the most important images pertaining to the topic of genital tract in this video. Now looking at the first important image, that is going to be from the male genital tract, and that is what is showing you the presence of this kind of a growth. I presume that most of you can make that out. This is going to be an example of a genital wart. Now instead of using the term genital wart, they can give you an image in the exam. They can ask you the name of the disease. The name of the disease that you need to be absolutely clear of is, it is going to be given the name of condyloma acuminata. Condyloma acuminata. The moment we are going to be talking about condyloma acuminata, a couple of questions which would readily come to your mind. Fact number one, this is going to be an example of a condition which is going to be sexually transmitted most of the times, and the causative organism that you associate with this kind of a condition happens to be the human papilloma virus. As most of us are familiar, human papilloma virus is going to be having two important subtypes, the low risk subtype and the high risk subtype. Genital warts are usually going to be caused because of the low risk subtypes, that means subtype 6 and 11. Whereas the moment we are thinking in terms of the subtypes 16 and 18, they are the ones which are commonly associated with a high risk of development of cancer. So be it the cancer of the male genital tract, that is the penis, or we are talking about the cancer of the cervical tissue, we talk about that the high risk subtypes are going to contribute to them. Now, one of the important features that is going to be remarkable so far as a human papilloma virus infection is concerned is what is appearing histologically over here, and what is clearly appreciated by you over here is this kind of a clearing of the cytoplasm. So there is a vacuolization that you find over here because of the involvement of the superficial epithelial cells by the human papilloma virus, and this phenomena is what most of you can easily recognize. It is going to be given the name of coilocytic atypia. So the vacuolization of the superficial epithelial cells is given the name of coilocytic atypia, and this coilocytic atypia is going to be one of the characteristic features that you associate with human papilloma virus infection. Now, why exactly should we be familiar with this kind of a fact is also because of the reason that condyloma acuminata is being caused by low risk viruses, but high risk viruses are responsible for causing development of carcinoma of the penis. So the exam questions which have been asked recently were with respect to an example of the virus which can contribute to development of carcinoma in situ, that is usually going to be HPV 16. We understand the fact that there can be certain examples of precancerous lesions associated with development of carcinoma of the penis, and I hope you can recall that from your surgical knowledge. That can be a condition, say for example the Bowen's disease. We talk about a condition given the name of the erythroplasia of the curate. We talk about a condition which is given the name of bovinoid papillosis. Also be familiar with the fact that as and when you're going to be making a mention of a condition in which the individual is going to be suffering from something like carcinoma of the penis, the part of the penis which is going to be most commonly affected in these patients is going to be the glans. So commonest is going to be affected area is going to be the glans, and please do not mark it as either the shaft or the prepuce. That is what you need to keep in mind. Of course, a lot of these patients are going to be having a rapid growth of the cancer which can be causing a damage to the male genital organ, and 50% of the times patients are going to be already having the presence of metastasis to the lymph nodes and elsewhere when they're going to be having the initial presentation. So all in all, what you just need to remember over here is recognition of the genital wart over here, the causative organism and the other diseases, as well as we need to be familiar with the concept of something like the coilocytic atypia. Talking about an example of an image which was asked in the exam relatively recently, this is an example of an image which is going to be showing you the histological appearance of the testicular tissue in case of an affected individual who presents to your clinic with a complaint of infertility. Now, to understand this kind of an image, it is important and pertinent that we have an idea about the normal histological appearance of the testicular tissue. So let us just talk about the fact that we are looking at the cross section of a seminiferous tubule, which is going to be having the presence of Sertoli cells, and which is also going to be having the presence of the different types of germ cells like the spermatogonia, the primary and the secondary spermatocytes. In the interstitial cells, we are going to be having the Leydig cells, and they are the ones which are going to be responsible for the secretion of the androgens. Now, having a look at this kind of a basic image, it is easy for us to understand and appreciate what was given as a question in the exam. And this is an example of a condition in which you find the interstitial cells are going to remain intact, so the Leydig cells are intact. But if you see the cross section of the seminiferous tubules, it would appear to you that the seminiferous tubules are going to be somewhat shrunken in diameter, as well as what can be seen over here is that you can make out the presence of only and only the Sertoli cells. You do not find any germ cells over here. So this is an example of a condition that you need to be familiar with. It is given the name of Sertoli only cell syndrome. Sertoli only cell syndrome. The condition is known by another important name as well. This is given the name of the Del Castillo syndrome. The Del Castillo syndrome. So fundamentally, this is going to be a young individual who is going to be having a presentation in the form of infertility, and histological examination would reveal the fact that this individual is having only and only the presence of Sertoli cells. Majority of the individuals who are going to be having this kind of a condition are therefore going to be having an absence of germ cells, and the reasons could be that there could be genetic factors, or there could be something like a gonadotropin deficiency, or there could be something like an undescended testicular history which could be present in these individuals. So multiple risk factors which could contribute to the development of this kind of a condition, that is what we need to have an idea. But the important fact is that Leydig cells are going to be appreciated, and I hope you can make that out. You can make out even the presence of those rectangular eosinophilic inclusions as well, which are given the name of the Ranke's crystals. Point to be remembered over here is that as and when you're looking at the Sertoli cells, they are the ones which can be recognized quite comfortably. And just for the sake of a previous anatomy histology question, you need to be familiar with the fact as and when you're going to be looking at the Sertoli cells are the ones which are going to be having the presence of an oval nucleus, and it is going to be having the presence of a punctate nucleolus. But easy for you to pick up that kind of a question in the exam based upon the fact that you do not see presence of any of these kind of germ cells, and therefore the answer for the question which was asked in the exam and what you need to have an idea over here happens to be the Sertoli only cell syndrome. An example of an image which possibly can be given in the exam, again showing and highlighting the same fact that you're going to be having the presence of the interstitial tissue, but what you can easily make out over here is that you have just the presence of the Sertoli cell layer without the presence of the germ cell. So again, that is going to be the presentation in case of the Sertoli only cell syndrome. Looking at the next important image, which is going to be a very important and a commonly observed presentation so far as the emergency is concerned, in which a young individual most likely is going to be having a presentation in the form of severe pain in the testicular area. This is going to be associated with the fact that there is going to be torsion at the level of the testis. The testicular artery is going to remain patent over here, but the vein is the one which is going to get compressed. That is going to result in a vascular compromise, and that is going to be responsible for causing the development of a hemorrhagic infarct. Now, the moment we are going to be talking about something like a testicular torsion, this is very commonly asked as a question in the exam, that one of the important differential diagnoses in case of a young male having an acute pain in the genital area, in the testicular area, could be something like a testicular orchitis. So infectious condition, that would be something like epididymoorchitis, or if I just talk about the infectious fact, the orchitis condition. So how would you distinguish between them? Couple of things which you need to be familiar with as a physician as well. One is an example of a test that you perform which is given the name of the Prehan sign. So as and when you are going to be lifting a testicular tissue, there is going to be relief in case of an individual suffering from orchitis. So that is going to be a positive Prehan sign, whereas individuals having testicular torsion are going to have a worsening of their pain because the tortuosity increases on lifting the testicular tissue. Second fact that you can understand over here is because you are going to be having the presence of a torsion, so that causes compression of the neural plexus as well, and that is going to be responsible for causing absence of a cremasteric reflex. Whereas we can understand cremasteric reflex is going to remain intact in a patient who is going to be having an inflammatory condition. So Prehan sign is positive in orchitis, as well as cremasteric reflex is going to be positive, which means it is present in case of orchitis, whereas in testicular torsion both of them are going to be absent. We also can talk about the couple of other signs that you are observing in the patient, something which I presume you have from your knowledge of surgery, given the name of the angel sign, right? So the important fact so far as a pathological concept is concerned is that yes, you look at the testicular tissue, it is not going to be white as you would find in case of a single vascular supply organ, but this is going to be present or associated with a hemorrhagic infarct for the reason I have just now explained you. So that is what we need to have an idea so far as testicular torsion is concerned. Okay, the next important question, the exam question is going to be asking you about the testicular tumors. Now, whenever we are talking about the testicular tumors, we did talk about the risk factors for development of testicular tumors, which includes testicular dysgenesis. We did make a mention of something like the intratubular germ cell neoplasia, which will just remind me of the fact that intratubular germ cell neoplasia can be associated with almost any type of a testicular tumor except, please remember the fact, spermatocytic seminoma. You need to remember the fact it is not going to be associated with a teratoma. So these are the ones in which we do not find the intratubular germ cell neoplasia. That's a very, very pertinent fact to be remembered. Fact number 2, whenever you're going to be talking about testicular tumors, there is going to be a particular type of isochromosome which the examiners love to go after, that is isochromosome 12p. Whenever we are talking about the testicular tumors, we divide the tumors into two major categories, the seminomatous and the non-seminomatous categories. Seminomatous tumors have got a practical significance that they are going to be the commonest tumors in case of an individual who is going to be a young to middle-aged adult. Read the question carefully. If the question talks about an elderly individual having a testicular tumor, you would answer it as a lymphoma. If you are talking about a 2 to 3-year-old child having a testicular tumor, the first differential diagnosis is going to be a yolk sac tumor. Please be familiar with the fact if the question makes a mention of a 10 to 11-year-old child having a testicular tumor, we would think in terms of a teratoma. Now, as and when we are making a mention of the testicular tumor, we need to be familiar with the fact that this particular tumor, that is a seminoma, is going to be characterized by the fact, as you can appreciate on the slide appearing in front of you, that it is going to be having the presence of enlargement of both the testicular tissue. There is going to be a fleshy homogeneous appearance, and you need to appreciate the fact that there is no hemorrhage and necrosis so far as this tumor is concerned. Histological finding in association with the seminoma is very commonly asked in the exam. That's a very important question, very important slide. You would be having the presence of clear looking polyhedral cells, and the reason why the cells are going to be clear looking polyhedral is because of the fact that these cells are going to be containing glycogen, which gets easily washed off. So that clear looking cytoplasm is what is going to be appreciated. Also, we need to appreciate the fact that there is a lymphocytic infiltration in the septal tissue. Lymphocytic infiltration in the septal tissue. So clear looking cells because of presence of glycogen and the presence of lymphocytic infiltration that you are going to be having over here is what is going to be absolutely characteristic so far as a seminoma is concerned. Sometimes instead of writing the word a clear looking cytoplasm, the question in the exam may make a mention of the fact watery cytoplasm or a glass like cytoplasm. That is what you just need to be having an idea about. Be familiar with the fact that seminoma can be having multiple subtypes, but one particular variant of seminoma which the examiners love to ask you because of its peculiarity is going to be the spermatocytic seminoma. So it is going to be slightly different from the classical seminoma that we talk about, in the sense that the age group of the patient over here is going to be much more. And fact number 2 that we need to remember, it is not going to be associated with intratubular germ cell neoplasia. Of course, there are other important differences that I just made a mention of in the main video section. So if you are able to recall about the concept of the large cells, the middle cells, and the spirine chromatin that I told you, that would be really good. But at least for the basic, be familiar with the age group of a seminoma, appearance, and the presence of cells with clear looking cytoplasm, watery cytoplasm, and lymphocytic infiltration in the fibrous septa. Now just to talk about the markers that they can ask you in the exam, because it has so happened that when they are making a mention of something like a testicular tumor, they would be making a mention of the markers as well. So you need to be familiar with the markers. The markers that we have in case of a seminoma include the KIT. Most of you can recall about OCT 3 and 4, and you can be easily appreciating the presence of a marker like NANOG. A lot of these are examples of transcription factors usually, and these are going to be the markers for the seminomatous tumor as well. Talking about the next important example of a tumor, which is a kind of a giveaway question, I want you to be familiar with the fact that this particular tumor is going to be given the name of a yolk sac tumor. The yolk sac tumor in the exam is also known by the other important name of an endodermal sinus tumor. Now, this kind of a tumor is going to be characterized by the fact that in contrast to a seminomatous tumor, it is going to be having the presence of hemorrhage as well as necrosis. The important fact with regards to endodermal sinus tumors lies in two important things. Fact number 1, this is a testicular tumor that is going to be seen typically in case of a child. So, the commonest tumor that you have in a child who is going to be having an age of 3 to 4 years. So this kind of a tumor is also known by the name of a yolk sac tumor, and that would remind you the fact about the histological appearance, which was asked as a recent INISET question as well. You have a central blood vessel in which you are going to be having one layer or ring of the tumor cells. There is an intervening empty area. You have another important layer of the tumor cells. So central blood vessel having two important layers of the tumor cells surrounding it, therefore giving it the name, it is given the name of a Schiller-Duval body, also known by the name of a glomeruloid body. Schiller-Duval body, also known by the name of a glomeruloid body. So we just need to have an idea about this particular fact, because that used to be an example of a one-liner question, fact-based question, but with the trend of the exam, what they can be presenting to you is a clinical picture. So child having a testicular tumor on examination histopathologically, that is having the presence of a Schiller-Duval body or glomeruloid body. We also need to be familiar with the fact that this tumor has got a significance, that there are certain types of markers that are usually associated with them. This kind of a tumor is going to be alpha-1 antitrypsin positive, and it is also going to be positive or having a marker as alpha fetoprotein. So young child with these marker positivity and the presence of a Schiller-Duval body, you have to think in terms of something like an endodermal sinus tumor or a yolk sac tumor. Talking about the next important example of a tumor that we need to have an idea, this is a tumor which is going to be characterized by the presence of lot of hemorrhage and necrosis, and the Keyword in this kind of a tumor mentioned in the exam stem question would be the fact that there is a tumor which is discovered incidentally, because this is one of those rare examples of testicular tumors which are not usually associated with enlargement of the testicular tissue. So the testicular size is going to remain normal, but what is going to be very characteristically seen over here is that this tumor microscopically would be having the presence of the syncytotrophoblast and the cytotrophoblast. Usually that is going to be made a mention of in the exam by the fact that the people affected by this particular condition are going to be having the presence of a marker like beta HCG. So when I talk about the fact a testicular tumor which does not cause enlargement of the testis but has a marker which is going to be something like beta HCG, you would think in terms of a clear-cut tumor that is going to be the choriocarcinoma. Choriocarcinoma. So choriocarcinoma is the one that you need to be familiar with over here, and grossly as well as microscopically you can appreciate quite a significant amount of hemorrhage and necrosis in this kind of a testicular tumor. Talking about the next important example of a testicular tumor which is going to be characterized by the fact that there is going to be appearance of the affected testicular tissue like this, and microscopically you would be appreciating the presence of more than one component. So this kind of a tumor is what is going to be given the name of a teratoma. The moment we talk about a teratoma, our knowledge of neoplasia comes handy, and we can appreciate the fact that this is an example of a tumor which is going to be arising from more than one type of a germ cell layer. Therefore, it is going to be having the presence of different types of tissues, and therefore the term sometimes used for this kind of a tumor is the presence of heterogeneous appearance. Now, why do we say it heterogeneous is because you would be having sometimes even grossly as well as more appreciated over here in the microscopic pattern, you could be having the markers such as the epithelial cells, you would be having the presence of cartilage, you have the presence of smooth muscles, you do have the presence of adipose tissue. So all that is suggestive of the fact that more than one germ cell layer origin of this kind of a tumor, and therefore that is what is going to be making it a bit unique. Also, more commonly, what we need to understand clinically and appreciate the fact is that teratoma is usually going to be malignant when it is going to be seen in case of the testicular tissue, whereas when we talk about a teratoma in case of the female, I mean the counterpart, as most of you understand, is going to be the dermoid cyst. That's usually going to be benign. So presence of a heterogeneous mass, or what is having a kaleidoscopic pattern in the microscopy, having the presence of the components that I did make a mention of to you, all that is suggestive of the fact that the tumor that is being talked about in the exam happens to be a testicular teratoma. Talking about the next important example of a tissue which is very commonly asked as well as observed clinically, so we need to be familiar with the involvement of the prostate tissue. The moment we talk about the prostate tissue, examiners can be asking a question on the inflammatory conditions affecting the prostate. That can be something like prostatitis. When we talk about the benign conditions or the non-neoplastic conditions, one of the commonest conditions that is observed in the patients happens to be the benign hyperplasia of the prostate. Now, this benign hyperplasia of the prostate most commonly is going to cause involvement of the periurethral zone, and because of the involvement of the periurethral zone, it is likely to cause compression of the urethra. Therefore, the patients are going to be having the presence of obstructive symptoms. A lot of the patients are also going to be having irritative symptoms like frequency, urgency, and nocturia. When we talk about the histological appearance of the benign hyperplasia of the prostate, what is important for us to appreciate is the increase in the number of cells. Hyperplasia, increase in number of cells. So we are going to be having in the prostate the presence of a basal layer of cells, and then there is going to be an inner cuboidal layer of the cells. So when you have too many cells, they obviously are going to be projecting into the lumen. And that's exactly what I wanted to appreciate in this kind of a slide. So one is the basal layer of cells, and the second is the extra number of cells projecting in the lumen in this fashion. That is exactly what is going to be seen as a typical feature in context of the benign hyperplasia of the prostate. Now, this is a simple fact which is going to be helpful in distinguishing a benign hyperplasia prostate slide from a patient suffering from carcinoma prostate. So when we talk about prostatic cancer, that would be an example of a condition which is more commonly going to be causing involvement of the peripheral zone. Therefore, the patients of prostatic cancer are not going to be having obstructive symptoms in the early stage of the disease. But at a histological level, so far as a pathologist view is concerned, you appreciate two layers of cells in case of the benign condition, that is benign prostatic hyperplasia. But in contrast, if you're looking at something like carcinoma of the prostate, you would just be having the presence of a single layer of these cells. So I want you to understand that when you can easily make out the presence of two layers of the cell, that is what is going to be suggestive of the presence of benign condition, but we have only single layer of cells, and that too, please remember, the single layers of cell is what is going to be suggestive of cancer of the prostate. In cancer of the prostate, I want you to be familiar with the fact you do not find the basal cells. There are no basal cells that you can appreciate in case of the prostate cancer. Another important thing to be remembered over here is that this kind of a slide can be given, which is more explanatory in the sense that this would be on the left side, the presence of a low power magnification. So you can see the presence of, that's the only layer of cell that you can make out in the slide. I will just enlarge it for you. You can immediately appreciate the fact that there is presence of a hyperchromatic nucleus. Cells are appearing far more darker as they should be, and there is just one layer of the cells, better appreciated at the larger or the higher magnification, wherein you can see for the presence of those malignant cells. Malignant cells, you obviously understand, are going to be having the presence of anaplasia, so they are going to be having the presence of a high NC ratio, and that is what is going to be giving it the dark appearance, the single layer of cells, absence of basal cells, what is seen in case of the prostate cancer. Now, another important thing with regards to prostate cancer is, for a histopathologist, important fact that you need to remember is the Gleason's pattern. Now, Gleason's pattern would be the fact that when you're looking at the slide of a patient suffering from prostate cancer, you divide and give a particular type of a score. So when we are talking about, we first talk about the grading, wherein we talk about the grade 1, where we are going to be having the presence of well differentiated prostate cancer. So well differentiated would practically mean that it is having the presence of the small uniform glands. As the glands become more poorly differentiated, we are going to be having the presence of more anaplastic cells, and that would be associated with grade 5. Now, why that becomes important is simply because of the fact that you calculate what is going to be given the name of the Gleason's score. So, Gleason's score is going to be calculated in an interesting fashion, which is what the examiners used to ask you way back in your second year med school as well. In the slide, you make out the most common histological pattern that is observed. That particular pattern which is most commonly observed in the slide is given the name of a dominant pattern or the primary pattern. Now, that particular pattern is going to be given a particular grading, like you would say either, let's say for example, the dominant pattern is having the presence of well-defined small uniform glands. So you would give it a score of 1. The second most common pattern that is seen in the slide, so that is given the name of the secondary dominant pattern, that is also going to be seen. Let us say it is on the other extreme. You have the presence of absolutely undifferentiated cells. You have the presence of extremely anaplastic cells. You would give it a score of 5. So when you are talking about the grading from a very well differentiated, which is having a low grade, to a very high grade, which is going to be having the maximum score being given like 5, you would calculate a combination. So two different histological patterns are observed, the primary or the dominant pattern and the second most common or the secondary pattern, and then you calculate the combined score. This is going to be important because this is going to be associated with prognosticating a patient and expecting the kind of response that we may get or to see for the further course of action after offering treatment to this individual. However, what I want you to appreciate over here is that currently we are having the presence of a modification of the Gleason scoring. So Gleason scoring was what I told you, A plus B, wherein A is the dominant pattern grade and B is the second most common pattern that you observe. What we are having is given by the ISUP, that is the International Society of Urological Pathology, and what they have done is they have just made our jobs easier in the sense that they have subdivided the Gleason score into various categories. So ISUP, the International Society for Urological Pathology, score grading 1 is when you get a Gleason score of 6 or less. When you're going to be getting a score of, let's say, 7, and this can be a pertinent question in the exam because this is going to be a small trick fact that you need to remember. You can get two mechanisms by which you can be getting a score of 7. Either you get a Gleason score 3 plus 4, in which obviously that means the dominant pattern was having a score of 3 and the second most common was 4, or you can get 4 plus 3. Remember, 3 plus 4 and 4 plus 3 are slightly different because in 3 plus 4 you are getting ISUP 2, and what we are getting in case of the Gleason score 7, in which we are going to be having a more aggressive pattern as a dominant pattern, you would be getting a score over here or the grading over here as ISUP 3. If you're going to be getting a score still greater, more than 7, that would be like 8 or that would be 9 or that would be 10. So that can be accordingly given the name of the ISUP 4 and the ISUP 5. Why that practically translates into the fact is that when you're going to be having a score of, let us say, something like 6 or less, so that would be group 1. So group 1 is what is going to be given the name of a low grade prostate cancer. Please remember that. Group 1, ISUP 1 is a low grade prostate cancer. When we are talking about the one which is going to be having group 2, the group 2 is what is going to be given the name of an intermediate grade. Intermediate grade. But as and when you are making a mention of anywhere close to group 3 to group 5, 3, 4, 5, this is what is going to be given the name of a high grade prostate cancer. So as per the International Society of Urological Pathology, it is important for us to appreciate that there are just three important grades as per them. One, which is going to be low grade, which means having a score of 6 or less than 6, which is ISUP 1. If you get ISUP 2, that is going to be intermediate. If you get a score of ISUP, the grade is ISUP 3, 4 or 5, then that is going to be a high grade. So the important pertinent question for all of you people who are watching this particular video and you have a target of cracking something like the AIMS PJ, the INISET exam or getting a good rank at NEET, you need to appreciate the differentiation between this. A Gleason score of 7 can be intermediate, a Gleason score of 7 can be high grade as well. Important is under which category of ISUP is it falling. If it is ISUP 2 grade, then it is intermediate. If it is ISUP 3, then it is going to be high grade. So keep that particular point in your mind from the perspective of a future exam based question so far as this new ISUP pattern grade is concerned. Now that would be an example of a slide which is going to be demonstrating what I was telling you earlier, that when you're talking about something like a benign condition, that is going to be causing involvement of the periurethral zone, therefore causing compression of the urethra and causing the symptoms in the patient. When we are talking about the cancerous growth, that is going to be peripherally located and therefore not initially manifesting in the form of causing an obstruction to the patient. The other question that can possibly be asked in the exam with regards to the cancer of the prostate, if you can just revise with me, that at a histological level, this is going to be an example of an adenocarcinoma. Fact number 2, this is going to be an example of a cancer which is going to be notorious for having a perineural spread. Also, what is going to be asked in the exam would be with respect to the different types of markers. So, one of the classical markers that we are using for making a detection of the prostate cancer happens to be the prostate specific antigen, and as and when the value of the prostate specific antigen is more than 4 nanograms per ml, that is going to be suggestive of a cancer. Please be familiar with the fact that we got a urinary marker in the name of urinary PCA3, about which we did make a mention of in the main video section as well. And if you are talking about a new marker which was asked in one of the INICET exam, to be specific the JIPMER exam, we need to be familiar with this kind of a marker, NKX3. So NKX3 is the one that you need to be familiar with. In fact, NKX3-1 is an example of a marker that is quite suggestive of the development of prostate cancer. Now talking about our discussion of the important images, relatively important ones from context of the female genital tract, we will be talking about an example of a mass that is going to be composed of smooth muscle cells, which could be an example of a mass which is going to be either intramural, subserosal, submucosal, associated with presentation in the form of a heavy bleeding or for that matter reduced fertility in case of a young female. What I am referring to over here is an example of a condition that is going to be given the name of leiomyoma. Now, as and when we are making a mention of leiomyoma, we just need to be familiar with the fact that leiomyoma has been now shown to be associated with the presence of a gene mutation, and the kind of gene mutation associated with leiomyoma happens to be the MED12 gene mutation. So far as the gross as well as microscopic characteristic finding of a leiomyoma is concerned, it is going to be having the presence of smooth muscle cells which are well circumscribed and arranging themselves in a whorled fashion. So when you are looking at a slide as well, you can make that out in the slide as well. You're going to be having the presence of what is being defined by the name of whorled pattern. So smooth muscles in a whorled pattern is what is suggestive of a leiomyoma, also being given the name of a fibroid. Now fibroids are important because they are going to be extremely common. They can result in development of anemia secondary to heavy bleeding in case of a young female. They can be contributing to development of reduced fertility as well, and they might as well be responsible for causing development of other manifestations like compression of the important organs like, let's say, the bladder. We need to be familiar with the fact that as and when we are making a mention of something like the leiomyoma or the fibroid, there are certain types of secondary changes or complications which may be seen over a period of time. One of the most common changes which is going to be seen over here in case of a leiomyoma or a fibroid happens to be what is given the name of a hyaline degeneration. We could be having the presence or development of what is going to be given the name of a red degeneration. We could be having the presence of a malignant transformation as well. So important facts regarding each of them that I would like you to make a mention of over here is that hyaline degeneration happens to be the commonest secondary change that is seen in case of a leiomyoma. If the exam question becomes very specific, that they talk about the commonest change that you would see in case of pregnancy, particularly second trimester of pregnancy, then you would answer it as the red degeneration. When we are talking about the important change, that is going to be the rarest change. So that would be usually a transformation of a leiomyoma into a malignant tumor. So that is given the name of a sarcomatoid change. That is going to be the rarest secondary change that is going to be observed. Now, one important question that has not been asked in the exam, but to my mind that can be an example of a very potent INI-CET based question, can be how to identify a leiomyoma with the help of a special stain like the Van Giesen stain. So with respect to the Van Giesen stain, all I would like you to understand over here and appreciate over here is that the smooth muscles are going to be getting a yellow color, whereas the collagen bundles are going to be giving you a red color. So whenever you're going to be staining the leiomyoma with the Van Giesen stain, what you can appreciate over here is that the yellow color actually is going to be present over here. That is what is giving you world pattern, and you are going to be having the presence of the reddish color, which is contributed by the presence of the collagen bundles. So that can be one important example of an image that can possibly given to you in the exam. Of course, I can always make a mention of the fact what I discussed with you earlier as well with regards to something like the cellular tibia and the cellular and the nuclear tibia, with regards to the fact that there is going to be presence of cellular atypia in the form of development of 10 mitosis per 10 high power field. And then if we are talking about something like the nuclear atypia, we are going to be making a mention of something like more than 5 mitosis per 10 high power field that is going to be observed so far as the malignant transformation is concerned. I mean, that is something which is going to be just one time asked question in the previous JETMER exam. So all I want you to understand over here is clinical presentation of a patient having leiomyoma. You need to be able to pick up the world pattern, whether the particular leiomyoma fibroid is an example of a intramural, subserosal or submucosal one, and then you should be able to pick up a special stain picture of leiomyoma with the help of a stain like Van Giesen stain. Talking about the next important image, which is going to be an absolutely giveaway kind of a question. What you are observing on your screen happens to be the gross appearance of an image, so very commonly given in your exams, that is suggestive of chocolate cysts. The moment we are talking about chocolate cysts, the condition that comes to our mind is the presence of ectopic endometrial tissue. And the commonest site for such a kind of a condition, which we term scientifically as endometriosis, happens to be the ovaries. Because of the fact that you are having the presence of the ovarian tissue over here, that is, the ovaries are going to be having the presence of the endometrial tissue over here. This is going to be undergoing cyclical changes, and because of cyclical changes, you would expect to have the presence of bleeding, which is going to be giving you this kind of an appearance, given the name of a chocolate cyst. Why do we need to be familiar with the concept of endometriosis? Is because of the fact that apart from ovaries, there are other important locations. Say for example, what I did make a mention of, the second most common location happens to be something like the uterine ligament. It could be having an association with something like the rectovaginal septum as well. We need to be familiar with the concept of endometriosis because of the fact that this is going to be contributing to the development of pelvic pain. For that matter, the lady could be having the presence of dysmenorrhea, and this can even be contributing to the development of the associated manifestations. Say for example, pain on defecation. Say for example, a question will make a mention of the fact a patient is going to be having pain on urination. So those kind of manifestations can be associated with something like endometriosis. If the endometriosis causes involvement of the peritoneal tissue, then that can be associated with hemorrhagic spots over there as well, which I showed you in the main video as well, and that is what is going to be associated with the term the gunpowder appearance of peritoneum. Gunpowder appearance of peritoneum. So gunpowder appearance of peritoneum, chocolate cyst in the ovaries, all that is suggestive of the condition that we are making a mention of over here, endometriosis. Just to have a revamp of what you have read in the main videos as well, the tissue over here is dependent upon the presence of the enzyme that is going to be given the name of aromatase, and you need to be familiar with the fact that you do have a very important role that is going to be played by prostaglandin E2. So that is what we need to have an idea so far as endometriosis is concerned. Talking about the next important topic, wherein usually this is going to be a topic which is going to be better and I presume clinically in a very beautiful way covered in the RR section as well as in the main video sections of gynecology, but then we just need to have an idea from a pathological perspective that when we talking about ovarian tumors, we classically have divided them into important categories like the epithelial cancers, wherein we talk about the presence of something like the mucinous cancers, the serous cancers, we talk about the Brenner cancer, and we do make a mention of something like the clear cell and the endometrioid cancers. When we are talking about the germ cell tumors, we have important examples including dysgerminoma, we have teratoma, we have got the presence of yolk sac tumors, and then we have got the presence of mixed germ cell tumors. Also, when we talk about the sex cord stromal tumors, primarily we focus on something like a fibroma, thecoma, fibrothecoma, and we at times do make a mention of the tumors like the Sertoli Leydig cell tumor. And definitely what I would like to understand over here is that we do have a small cell carcinoma of the ovary as well, in which we are going to be having a hypercalcemic type and the pulmonary type. So at a very basic level, you need to be familiar with the fact that ovarian tumors can either be primary or secondary, and then just having a gross look at this kind of an image, that each of these tissues is going to be giving rise to a different subset of ovarian tumors, about which the important questions are what we're going to be discussing in the next few minutes. Now, talking about ovarian tumors, we need to understand the fact that the epithelial cell tumors of the ovary are going to be the commonest ones, and we did make a mention of something like the mucinous tumors and the serous tumors in detail. I hope you can remember the fact that serous tumors can either be benign, they can be intermediate, or they can be malignant. The benign tumors are going to be the most common primary benign tumors affecting the ovary. The malignant counterpart has an important fact that it is usually going to be bilateral. Now, one of the important examples of the tumors that is appearing on your screen as of now is what is going to be given the name of the Brenner's tumor. Brenner's tumor. Now, Brenner's tumor has been asked in the exam recently for multiple reasons. Fact number one, this is an example of a tumor which has got a direct association with the presence of a group of cells which are going to be given the name of the Walther's cells. So, Walther's rest or Walther's cells are the ones which are going to be giving rise to this kind of a tumor. Fact number two about which we need to have an idea is that this is a kind of a tumor which is going to be having a classical appearance. Histologically, it is going to be having the presence of a transitional cell epithelium. Now, whenever we are going to be talking about the Brenner's tumor, we need to be familiar with the fact that this kind of a transitional cell epithelium can be seen at a higher magnification, and that could become another important question for the exam. The cells over here, if you can appreciate over here, the cells over here are presence of this kind of an appearance, which is going to be given the name of a coffee bean nucleus. Coffee bean nucleus. So just about 3 or 4 questions which are going to be asked in the exam so far as a Brenner's tumor is concerned, because it is having an epithelium which resembles the urothelium or the transitional epithelium. The origin takes place from the Walther's cell nests, as we call them, and the nuclear appearance of the cells over here is going to be the coffee bean nucleus. We understand the fact that a lot of times this tumor is likely to be benign and it is going to be causing only involvement of one side of the ovary. However, please be familiar with the fact that whenever we are talking about in general the surface epithelial tumors affecting the ovary, they are going to be having the clinical presentation in the form of an elderly female who is going to be having the presence of an abdominal protrusion, usually because of presence of an ascites, and this ascitic fluid is going to be having the elevated values of CA125. So that is a simple enough marker which is useful for making a diagnosis of the surface epithelial tumors of the ovary. We also need to be familiar with the fact that sometimes Brenner's tumors is asked in the exam, as has been done previously, because this is associated with the development of a pseudo-Meag syndrome. Talking about an example of a ovarian tumor which is asked in the exam, and that is going to be a kind of a quiz between you and me. So if I ask you an example of an ovarian tumor which is going to be the counterpart for seminoma, that brings a smile on your face, and that's the answer. This is going to be picked up in the exam as dysgerminoma. So that's a very first question that you need to keep an eye on. Counterpart in case of a female, but the counterpart that we're talking about is that female counterpart of seminoma that would be answered in the exam as dysgerminoma. Now, if you remember the histological appearance of seminoma that we discussed few years back in the same video, you would be appreciating the fact that you would be having the presence of what? Polyhedral clear looking cells. Why are they clear looking? Because there is going to be glycogen which gets washed off. Also, there is going to be lymphocytic infiltration taking place in the interstitial tissue, taking place in the fibrous septa. So please remember that fact that the question will make a mention of in the exam either like the counterpart point, or they make a mention of polyhedral cells which are going to be associated with lymphocytic infiltration in the fibrous septa. That is what we need to have an idea so far as a dysgerminoma is concerned. A third way of putting up a same question, they can be talking about an example of an ovarian tumor which is going to be having the presence of special type of markers. What were the markers? I want you not to look at your notes and answer this. The markers were, let's say, KIT, we talked about OCT3 and 4, and we did talk about NENOG. So different ways by which the examiners can be putting up that question, and by all means possible, I do presume that you would be cracking this question quite easily. Talking about the next important question, which is going to be a giveaway kind of a question. This would be an example of a tumor that is going to be given the name of ovarian teratoma, which most of the situations it is going to be an example of a benign tumor, as I did share with you, and for that reason it is going to be given the name of a dermoid cyst. Now, the moment we are talking about dermoid cyst, this is going to be an example of a tumor which in most of the individuals, most of the females, it is going to be an example of a mature teratoma. When you talk about the term mature teratoma, this is going to be an example of a benign tumor. The benign tumors are going to be having the presence of this kind of a karyotype, that is 46XX. In contrast, the tumors that I just now talked about 2 minutes back with you, which was the tumor which was having the female ovarian counterpart of a seminoma, which was dysgerminoma, that was more commonly associated with a condition like Turner syndrome. But over here, mature teratomas are going to be having this kind of an appearance that is associated with a karyotype that is 46XX. Now, to talk about a teratoma, easy for us to appreciate the fact that you are obviously able to find the presence of skin, you are having the presence of hair, you see the presence of mucin, you can be having the presence of adipose tissue, you can be having the presence of cartilage, you can have the presence of tooth. So practically just rewinding and talking about the fact that this is going to be having an origin from more than one type of a germ cell layer. please watch out for a question in the exam which will make a mention of the fact that if there is going to be a teratoma that is present in case of a prepubertal female, that is a dangerous teratoma, because this kind of a teratoma is likely to be malignant. So usually the teratomas are going to be benign, and typically when they're talking about the age group, let's say 25 years, 35 years, 40 years, so usually in the reproductive age group they are going to be benign, but prepubertal teratomas, watch out for differentiation fact, is going to be malignant in nature. But they can also talk about the fact is in case of teratomas, you can sometimes be having the presence of a skin tissue, and if there is going to be a skin tissue in case of a teratoma, that can undergo a secondary malignant transformation. Listen to my words carefully. If there is a skin tissue present in a teratoma, that can undergo a secondary malignant transformation. The kind of secondary malignant transformation seen in the skin over here happens to be something like a squamous cell carcinoma. There are situations at times when the individuals are going to be suffering from a teratoma which is given the name of a specialized teratoma. One example of which I did talk about in the main video section with you friends was given the name of struma ovarii. Struma ovarii is important for two reasons. Usually the question would be asking you in the exam that you are going to be having the presence of a functional thyroid tissue over here. So a lady who is going to be having an incidental detection of, let us say, an ovarian mass, and she was also having the presence of features suggestive of hyperthyroidism, that would very well go in favor of something like a struma ovarii. Fact number 2, struma ovarii, apart from the thyroid hormones, can also be having secretion of something like serotonin. So if there is going to be excessive amount of secretion of serotonin, that can be responsible for development of an ovarian carcinoid, and therefore you need to be keeping out a watch on these kind of questions. Ovarian mass plus carcinoid like manifestations, ovarian mass plus hyperthyroidism, they would go in favor of something like struma ovarii. All in all, an easy question, easy image for you to identify in the exam. Talking about an example of an image which we talked about just few minutes back with regards to something like the male genital tract as well. An example of a situation in which there is a presence of an ovarian tumor which is having the presence of this kind of a characteristic structure. Central blood vessel, layer of tumor cells, another layer of tumor cells having an appearance which is going to be resembling a glomerulus. So this is what is given the name of a glomeruloid body, alternatively called by the name of a Schiller dual body. Easy for you to recall that this kind of a structure is very much suggestive of which tumor? Yes, you get it right. That is suggestive of a yolk sac tumor or an endodermal sinus tumor. So the very fact that you're able to appreciate a Schiller dual body and pick it up in the exam would make things very easy for you. Talking about the next question, which is going to be given in the exam in the form of a history, wherein they talk about the presence of a patient who's going to be having an ovarian tumor, and then this patient is going to be having the presence of elevated values of beta HCG. The moment we talk about an example of a tumor which is going to be having elevated values of beta HCG, we would be thinking in terms of a tumor like choriocarcinoma. As in case of the choriocarcinoma affecting the testicular tissue, you can easily make out the presence of something like the presence of hemorrhage and necrosis. Now, why is this choriocarcinoma important for you to remember is because of the fact that this particular tumor is not going to be rising from the placental side. So, what I mean to say is that the non-placental choriocarcinomas are going to be much more aggressive, and they would be associated with poor prognosis for the simple fact that they do not respond very well to chemotherapy. One of the important facts that you have with respect to choriocarcinoma, which can potentially be given as an image-based question to you, is that you would be having the presence of two populations of cells. One population of cells that you can appreciate are the cells which are going to be having a dark staining nucleus, and they are going to be having a multinucleated and a dark staining cytoplasm. These cells are going to be the syncytiotrophoblasts. On the other hand, the second type of cells that we have are the cytotophoblasts. The cytotophoblasts are example of cells which are going to be relatively pale. They're going to be pale, and then they are going to be having the presence of a single nucleus. So single nucleus, pale cytoplasm, that is a cytotrophoblastic cell. And when we are talking about syncytio word means syncytium group. So you are going to be having a multinucleated cell, and that is going to be having a darker appearance. So this is how you are able to pick up something like a combination of a cytotrophoblast and syncytotrophoblast, and talking about the tumor that is going to be choriocarcinoma. Now talking about an example of an ovarian tumor, which I would be rather giving you in the form of a question again. Say for example, I talk about the presence of a tumor which is going to be responsible for causing development of precocious puberty in case of young girls, and the same tumor in elderly females is associated with a high risk of development of endometrial carcinoma. What's the kind of tumor am I referring to? Yes, you get it right. I'm talking about an example of a functional ovarian tumor. Now, when we talk about a functional ovarian tumor, an example of a tumor which is going to be very commonly responsible for causing secretion of estrogen. This particular tumor is going to be given the name of functional tumor, and the functional tumor I would like you to be familiar with over here is what is going to be given the name of the granulosa theca cell tumor. Granulosa theca cell tumor is going to be asked in the exams for four important reasons. Reason number one, this is an example of a functional tumor, so the kind of history that I shared with you. So in case of young girls, it can be responsible for development of precocious puberty. In case of elderly females, it has been shown to be definitely increasing the risk of development of endometrial carcinoma. In case of reproductive age group females, it is associated with endometrial hyperplasia. Therefore, it can be responsible for causing development of excessive menstrual bleeding. Reason number 2 why they would be asking a question on the granulosa thecal cell tumor is because of the histological appearance, for which we need to have an idea. You are going to be having the presence of a central acidophilic area, and you are going to be having the tumor cells which are going to be arranging themselves in this kind of a fashion. This kind of an arrangement of the tumor cells around a central acidophilic area is what is going to be given a special name. It is given the name of the Cole-Exner body. So earlier they used to be asking you one-liner questions, but with the current trend of the exams, they might as well give you a history suggestive of excessive estrogen secretion, and they would be then combining it with a histological finding wherein they talk about the presence of something like a Cole-Exner body, for which they would be asking a question. Question number 3 that they can be asking you is the kind of gene mutation that we made a mention of in the main videos, that is FOXL2 mutation. Remember, leiomyoma met well FOXL2 for something like granulosa theca cell tumor. Question number 4 can be an example of a marker by which we can specifically pick up a granulosa theca cell tumor, and that particular marker, I presume you remember, is going to be something like inhibin. So those are the 4 questions which are mandatory for you to have an idea so far as this particular functional ovarian tumor is concerned. Talking about the next important example of a tumor, this is going to be an example of a tumor which is going to be having grossly a whitish color. That's a tumor that we are making a reference to. This is going to be having a shiny appearance, and the tumor in question over here happens to be ovarian fibroma. The moment we talk about ovarian fibroma, you should be able to recall from our discussion in the main videos, it is associated with 2 important conditions. One which is going to be given the name of Meig syndrome, and the second condition is it is going to be associated with the basal cell nevus syndrome. Now, fact number 1, that when we're talking about something like Meig syndrome is going to be characterized by the presence of something like ovarian fibroma. The patients are also going to be having manifestation number 2 in the form of ascites, and the patients are also going to be having the presence of a right-sided pleural effusion. So, ovarian fibroma, ascites, right-sided pleural effusion, that triangle is going to be given the name of Meig syndrome. We need to be familiar with the fact Meig syndrome, as the name gives you a hint, is going to be associated with ovarian fibroma, and apart from that particular fact, the second fact that we need to have an idea is fibroma can be associated with a condition like basal cell nevus syndrome. Of course, the name gives you a hint. This would be an example of a tumor histologically characterized by the presence of fibroblasts, and there is a scanty stromal tissue. So pertinently for the exams, Meig syndrome and the association with basal cell nevus syndrome is to be remembered. Talking about the next important example of a tumor which they love to give you in the exam, this particular tumor is going to be given the name of Sertoli-Leydig cell tumor. Now, as and when we are making a mention of the Sertoli-Leydig cell tumor, we need to be familiar with the fact that this is going to be an example of a tumor which is a functional tumor, and the tumor is going to be having grossly a yellowish appearance. The tumor is going to be characterized by the fact that you can make out the presence of well-differentiated Sertoli cells over here. Now, that is going to be significant because this kind of a tumor, as I said, is going to be a functional tumor, and the tumor is responsible for causing secretion of androgens. So any kind of a question in the exam which makes a mention of the fact that there is a lady who is having an ovarian tumor, grossly having a yellowish appearance, or for that matter, she is having the presence of manifestations like hirsutism, she is having masculinization of her voice, she is having the presence of clitoral enlargement, that would be going in favor of a description of a tumor like the Sertoli-Leydig cell tumor. So functional ovarian tumor that we talked about, which was associated with estrogen secretion, that was few minutes back, which I told you precocious puberty, and then did I make a mention of something like endometrial hyperplasia and endometrial carcinoma, whereas this is the one which is going to be having the presence of androgen secretion. So watch out for the differentials between the functional ovarian tumors in the exam. Talking about an example of a question which can be given in the exam, this is going to be an example of a pure Leydig cell tumor, and pure Leydig cell tumor is going to be characterized by the fact that you have in the cells the presence of those eosinophilic rectangular inclusions. Those eosinophilic rectangular inclusions are what are going to be given the name of Ranke's crystals. So easy question for us to remember and answer in the exam. Ranke's crystals are a finding that you associate with Leydig cell tumor, and just have a mental picture of this kind of image. Very important image which is frequently given in the exams. Talking about an example of a question which is going to be associated with the characteristic finding that you would observe in the exam, that would be the presence of a bilateral ovarian enlargement. The moment you think in terms of a bilateral ovarian enlargement, the first important differential diagnosis you have to think in terms of is a metastatic ovarian tumor, and this kind of a metastatic ovarian tumor is going to be given the name of Krukenberg's tumor. Now, Krukenberg's tumor quite commonly is going to be contributed because of the fact that the patient is having the presence of a gastric carcinoma. Of course, the patients could be having the presence of colonic cancer, or they could be having the presence of the mucinous breast cancer as well. in order for us to identify the presence of a mucinous cancer. Say for example, I'm talking about something like a gastric adenocarcinoma, or for that matter a colonic adenocarcinoma, I would be looking at the microscopic picture, and the microscopic picture would be giving me a very important hint. You would be having tumor cells which are going to be having mucinous vacuolations, and because of those mucin containing cells, the nucleus is pushed towards the periphery. I hope most of you can make that out quite clearly, that when we are having cells in which the nucleus is pushed towards the periphery because of a presence of a mucinous vacuole, this is going to be associated with the term signet ring appearance. Signet ring appearance. That is one important thing that I would like you to be familiar with over here. The second important fact that I would like you to be familiar with over here is, how would you ensure, how would you distinguish between the fact whether this actually is an example of a metastasis, whether this actually is an example of a metastasis, or whether this is an example of a primary cancer which has, just spread to this particular area. So I just want you to be familiar with the fact whether this is a primary tumor or whether this is going to be an example of a secondary tumor, because sometimes even the tumors like ovarian adenomas could be having the presence of mucin, right? So but the easiest way by which we distinguish this is that if you're talking about a mets, let's say the mets are going to be coming from, and I would make a mention of over here the presence of something like a colorectal cancer. What we find over here is that can be appreciated on the basis of what I told you in context of the adenocarcinoma of the unknown primary. So we did make a mention of the fact that this is going to be having the markers like CK7, which is going to be absent over here, and then we can be using a marker which is going to be like CK20, which is going to be positive over here. On the other hand, as and when we are making a mention of something like the primary ovarian tumor, say for example something like the ovarian fibroma that we have just made a mention of, adenoma, do excuse me on that, then that is going to be having a positivity of CK7 and that is going to be negative for CK20. So that CK7 CK20 table, which we use quite commonly for identification of carcinoma of the unknown primary, is going to be useful and coming handy over here as well. For colorectal carcinomas, for most of them, we are going to be using this particular fact for differentiating between the primary tumor and which is going to be the metastatic tumor. So that is what we need to have an idea. However, from the perspective of an easy question, you just need to have a mental picture of enlargement of both the ovaries, and that is what is going to be associated with the term Krukenberg's tumor. Talking about an example of a tumor which is going to be characterized by this kind of an image that you get in the exam, wherein you find that there is a presence of a bilateral ovarian mass. Now, bilateral ovarian mass is more likely to be suggestive of the presence of a metastasis to the ovary. And when we are talking about metastasis to the ovary, the bilateral ovarian enlargement tumor is what is going to be given a special name, that is given the name of a Krukenberg's tumor. So we just need to be familiar with the fact that whenever we are going to be talking about the Krukenberg's tumor, you are going to be having the ovaries being enlarged on the two sides. Now, one of the commonest reasons, then that is the second question I would like you to keep in mind, for the ovarian metastasis happens to be the stomach cancer. Of course, we can be having cancers like the breast cancer, the colon cancer, which can also be having their spread to the ovaries. Now, whenever there is going to be a cancer which is going to be something like a gastric adenocarcinoma or a colorectal adenocarcinoma which is spreading to the ovaries, that is characterized by this specific finding that I am trying to show you over here. So I would like you to be familiar with this kind of a fact wherein you are going to be having the mucinous vacuoles which are going to be pushing the nucleus on one side, and that is going to be giving an appearance to the tumor cells over here, which is given the name of the signet ring appearance. So this kind of an appearance is what is going to be given the name of the signet ring appearance, which you can easily make out in the exam. An important query which is sometimes posed, I mean that is something which is a challenge to us at times in the lab as well as a common query, is that how would you distinguish whether this is an example of a primary ovarian adenocarcinoma vis-a-vis this is an example of a secondary tumor or a metastatic tumor. So the easiest way would be that we have talked about this particular fact when we talked about the table in which I explained you that we are using currently cytokeratins CK7 and CK20 to identify the carcinoma of an unknown primary. What we have over here is that, let me take the example of a patient who is having secondary ovarian enlargement because of a colorectal carcinoma. So in case of colorectal carcinoma, when we are using the markers CK7 and CK20, what we would find is that colorectal carcinoma is going to be negative for CK7, but it is going to be positive for CK20. And exactly opposite is what is going to be happening in case of a primary ovarian adenocarcinoma. The primary ovarian adenocarcinoma is going to be CK7 positive and it is going to be CK20 negative. Of course, there may be few exceptions here and there which may not be following this particular classification, but for the sake of a concept-based question, the use of markers like CK7 and 20 can be helpful in differentiating from a primary adenocarcinoma from a secondary tumor, which is going to be something like colorectal adenocarcinoma. So that is what we need to have an idea so far as the Krukenberg's tumor is concerned.